Welcome back to the Diet Doctor podcast. I'm your host, Dr. Brett Scher. Today I'm joined by Dr. Ian Lake, a general practitioner, GP in the United Kingdom. Now, Dr. Lake is a little bit different than most GPs as he himself has type 1 diabetes, and he is really focused on treating patients with type 1 diabetes with low-carb nutrition. So we're going to talk about his experience when he was diagnosed. He was diagnosed sort of late with type 1 diabetes at age 30, so an adult onset. And what his sort of progress was about treating his own diabetes, learning the role of carbohydrates and low carb, and then how he uses that with his patients. But he's also the organizer of 0-5-100 or the 0-5-100 project. 0 calories for 5 days, covering 100 miles. Now, on the surface, it might seem kind of crazy. Why would anybody do that? And that's some of the pushback he got. But as you'll see, he did it for very specific reasons to address very specific concerns about both people with type 1 diabetes and people without diabetes, about whether they need sugar and glucose, whether they can adequately run on no calories and on their own body fat, and whether the production of ketones would then potentially be dangerous for people with diabetes, and how low can blood sugar go. And they collected a wealth of data, and it was a great experiment, which they did safely and successfully, as you'll hear about, and sort of what the implications are, both for people as individuals and for healthcare practitioners. So I really hope you enjoy hearing from Dr. Lake what he wanted to accomplish out of this and what do you think he did accomplish. It was a pretty remarkable achievement, and I was very curious to hear about it and really enjoyed this interview. One quick addendum I forgot. Look, I don't know all the millimoles, and he doesn't know all the percentages when we could try and convert hemoglobin A1Cs, and we're trying to do the conversions on our brain as we go. So we did have a couple errors in there. So just be aware that 48 millimoles, which is the European version of the A1C, is 6.5% for the American version of the A1C. Otherwise, I think we got all our conversions correct, but maybe double check some of the conversions. I'm a Yankee and he's a Brit, and sometimes we don't speak the same language. Okay, after that, now enjoy the interview with Dr. Ian Lake. Well, Dr. Ian Lake, thank you so much for joining me on the Diet Doctor podcast today.
Hi, thank you very much. Thanks for inviting me. It's really, really nice. Thank you.
Yeah, well, I'm sure a lot of our listeners and viewers are anxious to hear more about the 0-5-100 project, and I'm anxious to talk to you about it. But just in case people kind of don't quite know who you are, haven't heard about you before, tell us a little bit about who you are, your background, and your medical practice. And let's talk about that first, and then we'll get into this exciting project you did about the 0-5-100.
Yeah, great. Well, I'm a GP, a general practitioner in the UK, which I've been now for over 30 years. I've come to sort of an arrangement with my type 1 diabetes where I use a keto diet combined with exercise, which seems to suit me very well. But when I was diagnosed, it was when I was in my 30s. So I was a late onset autoimmune type 1 diabetic. And presentation was pretty straightforward. It was raging thirst and going to the toilet a lot. And as a GP, I managed to diagnose myself, which was a bit of a breakthrough. I had a few ketones, but it was decided before the era of testing, really, for genes, etc., that I was a type 1, so I was commenced on insulin straight away. And I had a good prolonged honeymoon period of a couple of years or so. But then gradually, my insulin requirements increased over the subsequent 20 years of a high carbohydrate, a fairly standard diet that most people would recognize as a guideline diet. So 50% carbs in your diet, about 35% fat. And I went on that model because that was the training I had, and there's no reason to believe otherwise.
Right.
I was never brilliant at getting good control. I always found it difficult to combine diet with insulin shots. So it made it quite difficult for me to get good control. And my HbA1c for most of that diabetic career for the first 20 years was low to mid 50s. And towards the end of 20 years, my weight was going up, my insulin volumes were going up, and my HbA1c was going up.
So just
So
to clarify, low to mid 50s is about like 6.5, 6.8
yeah, something like
percent,
that.
somewhere around
Yeah,
there. Yeah.
it wasn't what I'd call ideal, but at the time it fitted the guidelines, and nobody was really too bothered about that. I mean, type 1 diabetes, isn't it, is thought of as damage or limitation more than anything else. Type 1 diabetes is thought of as a relentlessly progressive disease, and the better that you can control it, the more likely you are to avoid complications in the main. And of course, we all know some people have a worse sort of outcome than others. And it's not necessarily because of their diet, it's probably something to do with the genetics, something to do with the severity of the autoimmune disease, etc. So I followed that model for the first 20 years, and I sort of got away with it until I had quite a nasty hypo when I was caught out, sort of when I was camping and I had no supplies of glucose. And I was very lucky to sort of find some discarded food really on that occasion, which saved me. And
Mm.
roughly at the same time, I started to show signs of getting early retinopathy. Now, I'd read Richard Bernstein's Diabetes Solution, which is obviously the ketogenic type of higher protein, low carbohydrate diet. And I put it down for a year and a bit because I thought, well, that looks okay, but it's a bit extreme for me, and it's a bit too much fat, and that's sort of my training really. But after experiencing an early retinopathy, combined with a few of the other soft signs, so I was getting a lot of palpitations just walking upstairs, not irregular heartbeat, but palpitations. The worst thing for me was what's called postural hypotension. You stand up and have to sort of put your head between your legs for a few seconds to regain sort of this sort of sense of stability, and that was going on 6, 7 times a day. It wasn't very nice.
Mm.
Aching joints, feeling tired, slightly blurred vision, all the standard stuff that most people with type 1 would recognize. So when it came to it, I thought, well, I've got nothing to lose now. I might as well start trying another way of doing things. So I picked up Richard Bernstein's book again, read it, decided to try the ketogenic diet. I didn't have a continuous glucose meter at that stage either. So I was on manual, as it were. But from day one, I still remember vividly eating my first omelette, thinking about I'll be stroked out, have a stroke by the end of the day, all that fat. Oh dear, how bad it gets, isn't it? But
Yeah.
obviously that didn't happen. I got pretty good control from day one, and over the next 3 months, I was totally convinced that this was the way to go. And then I bought a continuous glucose meter, refined it, and for the last 5 years, my diabetes control's never been in the diabetic range, and most of the time, it's been in the normal range. So I'm quite keen to use my position, if you like, to try to convince most of the doctors in the UK that it should be a valid option for people with type 1 diabetes. People might not want to do it, but they should know it's available. Because for me, and I know for a lot of people with type 1, it's revolutionized their lives really. So
Yeah.
yeah.
Such a great story, and so much in that story to discuss. But your conclusion there, I really appreciate that it should be an option, right? It
Yeah,
doesn't mean it's for everybody with type 1
absolutely.
diabetes, but the
Mm.
fact that it wasn't even considered. So you wouldn't have known anything about this as a doctor unless you had gone through it yourself. And I think
Yeah.
that's one thing that's so striking, and that's why so many doctors don't know about it, and why it's so important for you to be spreading the word. But the other thing is your I guess progress through type 1 diabetes and through the complications of it are sort of accepted as just
Yes.
the way it is by so many doctors, and it is sort of a revolutionary thinking, unfortunately, to say it doesn't have to be that way.
Mm.
um, and also the way you were controlling your blood sugar, you said it was by the guidelines. So my recollection of the guidelines, at least here in the US, is you want to control to an HbA1c of around
Yeah.
7%. And it's really not that good, is it?
No. No.
No, but so why do the guidelines say 7 is okay when it really still puts the patient at significant risk of progressive disease and complications?
Yeah, that's interesting. I think the biggest problem is 7 is considered a pragmatic figure between complications and hypos. It's quite a lot of
Hypos meaning low
evidence,
blood
low
sugars.
blood
Yeah.
sugar, because
Yeah.
every time I present my HbA1c to my doctor, they say, "Oh, you must be having a load of hypos." I said, "No, you just have a look at my CGM. I'm not having any hypos. The evidence suggests you have 5 times fewer, which is probably right." But people are, obviously quite rightly scared stiff of hypos because it's dramatic, and nobody wants to have such a dramatic situation. Running slightly high is clearly safer, and it doesn't cause any immediate complications, but clearly you're stacking up problems for the future. And an HbA1c of 7% or 48 millimoles per mole, I think that is the pragmatic figure based between complications and hypos, based around a 50% carbohydrate diet. Now, with absolutely, so it's based around the 50%. Everything's based around 50% carbohydrate diets. The recommendation for statins based around 50% carbohydrates, etc., etc. So when it comes to a keto diet, I don't think 48 or 7% is particularly ambitious. Really, I think you can go lower than that.
Yeah, and I think that draws a wonderful comparison between how we think of things from a drug approach versus a lifestyle approach. Because
Yeah.
when you're talking about insulin and dosing insulin for all the carbs you're eating, which is a very inexact science, there's going to be some error and you're going to have hypos. But once you get rid of the carbs, you really eliminate that, or not eliminate, but drastically reduce that variation. So a lot of people think of reducing carbohydrates as improving glycemic control at the top end, which it does. But for type 1 diabetes, it's also about controlling it at the bottom end, at the hypos, which I think is so important as well. Now, when you started doing this for yourself and then for your patients, it's still very uncommon, and I'm sure was even more uncommon at the time that you did it. Was there a lot of kind of pushback and a lot of things you had to overcome, a lot of resistance you had to overcome to say, hey, actually, this does work and it is a viable option?
I think in the main, there's polite indifference. People will listen to you, but really not take it on board. Very few people will actually ask me directly, "How did you do that?" Which I'm probably they don't want sort of a 45-minute monologue, but curiosity is the key here. Following the guidelines, will get you to a level. But I think we need to rethink the guidelines, it seems to me that the low fat sort of idea of managing your diet is so entrenched as a fact. It's very difficult for people to get their head around it. And the other thing that's established almost as fact, which I know to be untrue, is that you need to eat sugar in order to get energy. That's almost a given. Oh, where are you going to get your energy from? When when you do your runs, where are you going to get your energy from? When you go to all these running events, 10Ks, half marathons, whatever, you always get a goodie bag full of energy bars, and and it is just not true that you need sugar for energy. And I think that is also sort of very hardwired in clinicians' thinking, and part of the reason for trying to sort of do other projects around type 1 management was to show that really you just do not need to eat sugar because your body will make enough of it for you. And once we get those messages out there, that you can safely burn fat and you don't need sugar for energy, I think that will get us a long way. And also more pertinent to type 1 diabetes is that you don't need carbs if you're taking insulin. Insulin is a hormone replacement therapy. You need the right amount of insulin at that moment in time. Now, we're never going to get it right as type 1s, even with the most rapid insulins and the best pumps. You're never going to mimic exactly this situation that was in your body when you had a functioning pancreas. But you've got to just try your best to minimize the amount of insulin you need, because you need much less than you think you need, to be honest. And I want to talk about that a little bit more later. Um, so, the physiological dose of insulin is relatively small. I mean, I started off when I was carbing up, before I went keto, at about 40 to 45 units of insulin total a day. Now I'm on about 20. So that's half the dose of insulin, and that can only be good. Because the other problem with injecting insulin to such high volumes, more than your body physiologically needs, is that, of course, you're giving yourself essentially hyperinsulinemia, high levels of insulin in type 1 diabetes. And if you've got a family history of type 2, or you're otherwise vulnerable to type 2, you're probably going to promote type 2 diabetes on top of type 1 diabetes. And I think you could call that an iatrogenic illness, an illness caused by the treatment process, rather, um, rather than it's a side effect of the treatment. Now, insulin is a life-saving drug, and I'm nothing. If the manufacturers stop producing insulin tomorrow, I'll be in trouble in a week. But because it's a life-saving illness, if you had to have complications as a result of that life-saving illness, well, you'd have to weigh up the balance and say, well, that's probably worth it. But I think there's enough evidence for the very low carbohydrate diet in type 1 diabetes to suggest there are options for us. In the UK, based around the current evidence that we have, the National Diabetes Audit, which collects about 96% of the type 1 population data, suggests that to get to 7%, fewer than 10% of the type 1s actually get to 10 to 7% HbA1c 48, which is terrible. So
Wow.
we're
Fewer
working
than
on a
10%? Wow.
10% success rate. 30% get to 56 millimoles per mole, which I think is 7.5. I'd have to check that.
That's about
Um,
7.5. Yeah.
yeah, but it's a relatively poor percentage, and it's not really going up as a result of
Mm.
technology. Combine that with the type 1 grit study done by David Ludwig and reported about a year and 2 years ago, where 90% or more of type 1s on a keto diet were achieving 7%. So you have to say, well, if 10% can make it on high carb diet, conventional management, and 90% on keto, we should definitely be offering patients that as an option for management.
Yeah,
And that's
that's
really a strong point we have to get across. We've got to rethink our management of type 1 diabetes before we cause any more damage. Because at the moment, it's what I call iatrogenic damage. It's possibly, it's not necessarily reversible, but preventable, that we're all going to get complications to such a level. We've
Yeah,
got to rethink.
such a great point. And in my training and everything I remember about type 1 diabetes, it was never mentioned about the dangers of too much insulin and inducing type 2 on type 1. That seems, at least from my recollection, a pretty recent discussion within the
Mm,
past maybe 5 years. It's in the past couple years has gotten even more attention. But so important because, like you said, insulin is a life-saving medication. And that's what people focus on. And you're right. People accepted any potential downfall because they didn't see another option. But now
mm,
there clearly is another option. But like you mentioned, you have to overcome a lot of ingrained teaching about,
mm,
like you said, eating this fat, you're going to stroke out any minute. I mean, that's
mm,
how powerful this teaching is.
mm,
And if you need energy for exercise, you need your carbohydrates.
mm.
But not true. So tell us about your sort of exercise background and what type of training and exercising you've been doing and what your fueling up looked like before and what it looks like now.
Yeah, okay. Well, I've never been. I've always liked the great outdoors, so I've always been an active person. But I wouldn't call myself an athlete by any stretch of the imagination. I'm a casual. I'm a jogger, and I do a bit of cycling, and I have done a bit of mountain biking, that sort of stuff. On a Sunday, and my regime when I was sort of full time working really was sort of 3 or 4 days a week at about 6, 7K, something like that, or a reasonable cycle ride, but no more than 3/4 of an hour of exercise. Most of that, I would try to get my glucose level up above 10 to get started, and then hope it wouldn't trickle down too much throughout the exercise and manage any hypos as you went. Mostly, I didn't get any hypos. It actually went higher because I was sort of overcompensating. Certainly for things like half marathons, it's quite difficult when you're, trying to complete something without stopping. It's very inconveniencing to have a hypo. Certainly, CGMs are useful, but they often report to you about 15 minutes after you realize your symptoms are of a hypo. So you're always behind the curve. So beforehand, it was carbing up, having gels available, measuring your glucose regularly. That's before the days of a CGM, and having pretty erratic traces, to be honest, and tending to run higher rather than lower, really for safety's point of view, because I tend to go out on my own to do runs in the hills and things, which we've got some lovely hills around here. So you can be out for an hour or so just on your own. Um, and obviously, when I went low carb, I realized it was very easy. to keep a good glucose profile. And then it got into my head that yes, you can actually fast. I was a bit behind the curve with that, but yes, you can actually fast before exercise, and you get even better control. So every time I do any sort of 10Ks, half marathons, whatever, I don't do many competitive. I don't do many organized events anymore. I tend to just go on my own for those sort of distances. But I rarely eat before I go. I prefer now to be fasted, and I think for me that controls things very, very well indeed, because I don't need much rapid acting insulin at all, and it's of course the rapid acting which causes the problems. And
So if you don't eat and then you go out and exercise, though, are you putting yourself at risk for hypoglycemia?
it doesn't seem to be, because my insulin volumes have reduced by half, and hypoglycemia on very, very small doses of insulin, 1, 2, 3 units. I rarely inject more than 3 units of insulin for a meal now, where I was injecting 8 to 10 in the days of high carbing. So with that tiny amount of insulin, you're rarely going to get into big problems. And I probably, if my glucose was less than 7, I probably wouldn't inject anything at all and just let the long acting sort of take the slack really, and it seems to work quite well. So it's
Now, if,
my choice now to do that.
right, right. So now if someone wants to try this out, are there certain precautions they should take, though, ahead of time to make sure that they don't get into trouble with hypos?
Absolutely. I think you've got to get fat adapted, and you've got, if you're going to do this sort of very low carbohydrate diet, you need to be fully fat adapted so that, you can burn glucose very efficiently from your body's own sources. So you don't need to eat it. And obviously, then in sort of exercise I do, which is prolonged sort of steady exercise, your body will quite happily burn fat all day, and for more than that if necessary. But if you're not fully fat adapted, you may find a little bit more difficulty handling your glucose. So get fat adapted first, and but if not, monitor, and just cut your carbs down, and be prepared just to take glucose rescue tablets as soon as you feel hypo. If you
Yeah,
have
good
no
point.
hypo awareness, you should be on a CGM or something from your healthcare provider.
Right, and
Yeah.
always having those tablets with you. Yeah, and what sort of time frame do you think the fully fat adapted encompasses?
I think you can do it. We just done a project, and you can do it in 2 weeks easily. You can get fully fat adapted in 2 weeks if you do a lot of exercise. Most people would say 3 to 4 weeks, and obviously once 3 months are up, you're well into it, and you're also very good then at managing your glucose and managing your
Right.
insulin around that. So a couple of weeks, 3 weeks to get fat adapted, probably up to 3 months to get your insulin adjusted, so you're perfecting it. But then just try, really have a go, and just 20 minutes, half an hour here and there, monitor with your CGM, be prepared to rescue with the glucose if necessary, and refine it. The CGM is such a remarkable device. I can't do without one now. I had one that didn't function for a week. I had a software issue, and it's been awful. It's reacting. Then you're reacting to glucose rather than being proactive with your insulin. So
Yeah.
you can't see
So
the trends.
yeah, very interesting. I mean, so CGMs basically designed for people, or continuous glucose monitors, CGMs, designed for people with type 1 diabetes, and so
Yes.
becoming so invaluable for that. And we had a podcast episode with Dr. Casey Means, who's now using CGMs for the everyday person without
Yeah.
type 2 or type 1 diabetes, and all the things we can learn. So really kind of the emerging tool of the new era of metabolic health, which I think is pretty remarkable, but really invaluable for people with type 1 diabetes. Yeah. All right. So that's a good background of who you are, your thought process, and how you got to this point. But now, somehow, you then take this jump to 0, 5, 100. So 0 calories over 5 days, covering 100 miles. So tell us what led you to draw this up and create it.
Okay. Well, I'm getting a bit frustrated, really, that the sort of low carb option still isn't available. So over the years, I've been collecting from specialists and healthcare professionals sort of reasons why they're a little bit concerned about the keto diet in type 1 diabetes. And it falls into a few categories. The standard one, you must have sugar for energy, which is a general category. And then there's the one, if you're taking insulin, you must have carbs. And of course, you can't argue with that. If you're taking insulin and you have a hypo, you must have carbs. But in general, as I said a bit earlier, if you're taking sufficient insulin for your needs at the time, you don't necessarily need carbohydrates as part of your diet. The other one is that if your body's burning fat, you're producing ketones, and if your body's burning fat, it's gone into starvation mode. Uh, there's a half a grain of truth in that, but by and large, if you're nutritionally complete in your diet and you're getting enough calories, you're not in starvation mode. Your body's just flicking into a fat burning metabolism, which is, one could argue, and I certainly would argue strongly, that's probably the natural diet for the human animal, the natural metabolism for the human animal. And the last thing, which is very, very prevalent, is that if you're in nutritional ketosis, so if you're burning fat, not taking many carbs, you're very you're at high risk of diabetic ketoacidosis. And of course, those two things, apart from the word keto and osis, the word acid in the middle, doesn't mean that it's related at all, and it isn't. If you've got sufficient insulin in your body for its needs at the time, it's almost impossible for you to go into ketoacidosis. So I thought, well, how can I roll up all those concerns into one project? And I started to hear a lot of people saying, in conferences, oh, your body's got enough fat to last for days and weeks. If not, you got 20,000, 30,000 calories of energy stored in your body to be used for energy. So I thought, well, okay, well, let's examine that. We're all talking about it. Let's actually make sure we're right. So let's do a project to burn, say, 20,000 calories of energy. So that's 4,000 calories a day if you're going to run it. So we thought 4,000 calories, 20 miles a day. So that's going to take us to do that 5 days. So let's try just 5 days. That seems a challenge, but it's sort of within the safe zone. Are you going to burn any body protein, sort of any muscle protein? Probably not, but it's within the safe enough zone not to need to worry about that. And it would certainly stretch the idea of fasting to say that, well, intermittent feeding is actually okay. So we thought, well, let's stretch fasting out to 5 days, examine our body fat burning using a breath analyzer, sort of metabolic breath testing, measure our ketones, wear continuous glucose meters, do mood scores, hunger scores, and see where we go with that. So that was the start of it. Took a bit of advice from a few people. Oh, can I do that? Can I join you? Yeah, I've got to do it. So we started off with quite a big group, really, of people who were quite enthusiastic. It was going to happen in May, but then the coronavirus sort of intervened. But all those people have still kept on, and we've got a great advisory team, and we've knocked it about, and we've thought about it, and we've thought about the implications and the complications, and we've all done our training and our fasting, and it seems to have been a good idea to have even thought about doing it. We haven't publicized it ahead because it's such a weird concept in type 1 diabetes that I thought we'd get so much negativity. I'd be under a lot of stress to actually do it, and feel pressurized to want to do it. I mean, this is an experiment. It's an exploration. We had 3 type 1s keen to do it. We all trained up, but unfortunately one couldn't get over to the UK because of COVID quarantining rules. But we were confident we could do it, and we wanted to finish it and then say, well, here's the data. And so that's what we tried to do. And we had 8 people on the whole project. 2 were type 1s, 4 overall were healthcare professionals, and 4 were very interested in metabolic health. And 2 of them had actually sorted out their metabolic health with a very low carbohydrate diet. So they were true believers in the idea. And then we managed to get an Olympic rower, James Cracknell, who's got a couple of gold medals for Great Britain, and he joined us later on. He joined us about 3 weeks out, but he was very good to have on board because he understands intimately the science of carbohydrate loading for sport, and he learned a lot from just watching what we do and understanding that sport at the top level has very little to do with most people's lives. And,
Yeah.
Formula One racing cars have very little to do with going to the shops, to the supermarket. Although
Good
the
analogy.
technology is the same, they're at a totally different level of performance. So
Right, but 20 miles a day for 5 days, I mean, that is a challenge for anybody under any circumstance, and then to make it with no food, makes it even a greater challenge, so, eh, and I guess sort of because of that, you did get some negative pushback. I mean, people, I'm gonna quote some things, people called it a daft stunt, reckless, irresponsible, encouraging eating disorders. I mean, there was quite a bit of negative press, especially in the UK, about it. So, how did you handle that as you're preparing for this? And I guess one, did you have doubts and second thoughts when you heard this? And what was your response?
we had tried our very best to work out our responses to everything ahead of the project, but we wanted to get the project finished before we got publicity. But that didn't happen. Publicity got out. Um, we were a little bit concerned about the eating disorder side of it because that's clearly, if you're actually saying to someone, well, you can actually run on your body fat and you don't need to eat. Yeah, I can fully understand that may be a concern to people, and that we sort of spent a lot of time trying to work through that. But we have managed to talk to people in the eating disorders field, and we're having a chat with them in about, well, soon, to talk through some of our findings in eating disorders, because it may actually be very useful, some of the information we've found from our project in retrospect. So far from promoting eating disorders, we may be actually helping to improve the management of eating disorders. But that's something
Interesting.
for another time. But it's really based around the low glucose levels that we found when we were running,
Hmm.
the non-diabetics especially.
Yeah. So I guess does that fall into the reckless and the irresponsible quotes that people were making, that it's dangerous, that you're going to harm people? Was there a part of you that said, "Oh, maybe we are going to harm people," or were you pretty confident the whole time that this was going to work out very well?
I was going to do it come what may. I thought it was a useful contribution to the keto field, and I was prepared to take a risk on that, and take a risk on the fact that we'd all make it, and because I knew we would. And as it happened, all eight of us started, all eight of us finished. There were no injuries, no one had any problems, and everyone at the end was feeling a lot better than they did at the start. In fact, it was easier for most of us. Well, for all of us, I think, than we thought it would have been. It
Wow,
wasn't a
that's
problem. And of
remarkable.
course, 20 miles, you can choose to run a walk and you're still going to get through the day. So there was a buffer there. I mean, I
Yeah.
think I think I ran about just over half of it and walked about half of it. Some people ran it all. Some people decided to walk it all. But it's 4,000 calories roughly a day. So it's quite a. But the interesting thing is, not many of us lost a huge amount of weight. I predicted I'd lose 3 kilograms, and I lost 3.5 kilograms. Some people only lost 2 kilograms of weight,
That is
which is
surprising.
phenomenal.
Yeah.
The average was about 3.5 kilograms between the eight of us. Very
Yeah.
interesting. It shows you can't really exercise off your weight.
Right. And I think it's important to mention that you had safety measures in place, that everybody was being very closely monitored.
Absolutely.
Assume you had a safety team and everybody had CGMs and was getting regular check-ins. So it's not like you were just going out on your own willy-nilly and doing this. It was very well organized, with a lot of safety measures in check. So very,
Absolutely. It took us 7 months to plan it. It took lots and lots of toing and froing with conversations with people who were experts in the field of metabolic health and low carb. Um, we did a lot of training. All of us did a lot of fasting, and we did a lot of running and fasting. And the diabetic people with diabetes, we did a lot of running, fasting, and monitoring. So by the time we came to the start line, we were well prepped, and also we had, as you say, lots of safety measures in place.
mhm.
We had lots of ways of finding people, because partly because of COVID rules and partly because everyone did their own thing. We were spaced out en route, but there's plenty of hydration stations. There are other doctors running and other doctors supervising. From vehicles. So it was a very tightly planned operation, as you'd expect of something where there's such a responsibility to deliver the right message safely.
Right. Right.
Yeah.
So you obviously didn't eat anything. What did you drink? Was it just water the whole time?
Water and black coffee and black tea, mostly water, to be honest.
Yeah.
Interestingly, at the end, coffee didn't have much appeal. It's funny, a taste went for coffee, but it's mostly just water, really. Yeah.
Okay. And so what was the experience like for you? I mean, you already sort of hinted that it got easier as it went on. But tell us about, the first couple of days, what you felt, and then what changed and when it changed.
Yeah, first day was great because 20 miles, we did 23 or 4 that day, I think, but it was a lovely sunny day. We were all up for it. We were all full of enthusiasm, and
Right.
the day went quite quickly, to be honest. It was quite a sociable day because people were getting to know each other. Some were walking sort of reasonably close to each other, COVID permitting, and we stopped off at one or two of the towns to have some water and at a cafe. It wasn't all hard work, and it was fine. It was all good. Day two was okay, a bit achy for me from muscles, but good recovery the next day. Day three was by far my worst day. I think I had problems hydrating. Wasn't sort of taking care of hydration. Bit tired at the end of day three. Day four was a wonderful day. Woke up full of energy, brain was wired, and I felt I could have run twice the distance that day. And I ran the
Wow.
whole thing that day, and I had energy to spare. I thought, well, should have just finish it today, do an extra 15 miles. Um, but didn't. But it was great. I thought, wow, this is amazing to get this far with this. You see, it wasn't starvation. This is what you have to remember. I wasn't starving. I just wasn't eating food because I had enough internal supplies to use.
Yeah.
So it wasn't starvation, and I was well nourished beforehand. I knew what my minimum weight was, so I stacked up my weight ahead of it, so I was ready to go. Bit like these sort of animals that do big migrations. Really, we were all ready to
Right.
go, and then we were able to use the fuel sources that we'd stored up to actually use throughout those 5 days. So it wasn't starvation. Starvation is when you're nutrient depleted, your fat stores have gone.
Right.
When that's when you've got an eating disorder, and then when you stop eating, that is true starvation.
Which is an
And
important caveat. Anybody who is in that malnourished or underweight
absolutely,
category should not try. So you
absolutely,
purposely
yeah,
made sure nobody was in that category. Yeah.
absolutely, yeah.
Yeah. And so sort of kind of contrary to what I think most people would think, that as it went on, it got easier and it got better at day four. Most people think, oh, you must be getting exhausted and so fatigued and starving. But no, it actually got better by day four and day five. I mean, that's pretty remarkable.
That was a pleasant
Yeah.
surprise to find that, and it was across the board. We did mood scores, we did hunger scores, and we did sleep scores. I think the
Yeah.
amount of ketones we're having swilling around our brain, they kept us very active. A lot of people didn't sleep that well. Sleeping was an issue for quite a few people because we were sort of
Interesting.
wired up, but we weren't tired. I mean,
Yeah.
I'd slept about, I don't know, 6 hours on and off throughout those 5 days per night.
Mhm.
And my fourth day, was great. So
Yeah.
it wasn't, the sleep didn't sort of hinder my performance. And certainly afterwards, the next morning after the whole event, it was as if I hadn't done it. I wasn't aching at all. I wasn't exhausted or tired or anything. It was very straightforward. So
Yeah, that
good.
speaks volumes. Yeah.
Yeah. Yeah.
And did you run into any trouble with blood sugar or insulin? Did you have any issues with that?
Yeah. I had the problem with transitioning from, I'm normally on about 20 units of insulin a day. An interesting finding was that when I'm fasting, I can get down to about between 4 and 6 units a day.
Wow.
So there's something about insulin resistance, something about, glucagon and food that kicks your sugar levels up. So the background insulin is probably, we need something I'm interested in looking at in a bit more detail at some point. So transitioning down from 20 units to 6 units is an art form. And I, over a sort of, I don't know, I suppose I did 4 or 5 3-day fasts during the training phase. So I was able to sort of work out roughly my insulin transition downwards. But on day one, I elected to take some glucagon rather than glucose. As you know, glucagon is the hormone that counters the action of insulin. So if you have a low blood glucose, you can rescue it with glucagon. I wanted to do that, one, so I didn't take as many calories as I might otherwise do, and two, just to see if glucagon was effective during a fast. I'd proved it in training that glucagon has a response up to 3 days of fasting. Because a big
Oh,
worry amongst diabetologists is if you're on a keto diet, you run out of something called liver glycogen, and that's the substrate glucagon works on. So if you end up in hospital in a hypoglycemic coma, they can't rescue it necessarily with glucagon, which is a standard drug that they would use. But I think I showed that is not the case. It works certainly to 72 hours, and I used it twice during the run. But unfortunately, the big side effect for me was nausea. So I decided not to use it after 2 days. I was hoping to use it for 5 days, but I used a total of 18 grams of glucose tablets over 3 different times to rescue symptomatic hypos, a little bit tired when running, nothing exciting, nothing like it's going to pass out, no sweating, no palpitations, nothing like that. But you just know. And my glucose was running at about just under 3, but otherwise asymptomatic. But that's the other interesting thing. The people that weren't diabetic who were wearing CGMs and doing this, two of them managed to keep the CGMs on and get good data. For much of the time, those two were running well under 3, completely asymptomatic.
And it's stuff like below 60 or so, right?
60
for milligrams per deciliter, just for the conversion.
It's divided by 18, isn't it? So 54, yeah, 60. Yeah.
Yeah. Okay.
Something like that. So what that shows really is that do we need to redefine what a low glucose is on a ketogenic diet?
Yes.
Because if people are functioning less than 3, fully functioning, getting through 3 days of glucose under 3, feeling on fat and feeling great and having no symptoms whatsoever, clearly their brain isn't being starved of glucose. And that has important implications in things like anorexia nervosa, where it's well known that people who are starving and fasting at the same time have low glucoses. But is that just a normal state in this condition, or is it pathological? And that's something that I'm not expert in, but that's sort of something that will be sort of talked about, I think, in the future. So observing that our glucose levels could run lower on a fat adapted state is quite an interesting finding.
Absolutely. And then what about ketone levels?
Did
you run into any trouble or have any concerns
none
about
whatsoever.
elevated ketones?
Now, if anyone's listening to this who's into sort of high carbohydrate, ketone levels of between 3 and 5 would actually terrify them. But my ketones were mostly running at about 3. I had one 5.7, couple of 2s. They were running well within the nutritional ketosis levels, and I tested them twice a day for 5 days. And the day after, it was running at 2.1 when I'd actually refed. And my normal ketones run normally between about 0.6 and 1. So yes, I was in more ketosis as I was running, which I'd expect, but there's no way I was in the diabetic ketoacidotic range. And my glucose levels were in the normal range between 3.5 and 7 for at least 90% of the time, if not 100% of the time.
Yeah.
So I had a flat glucose trace for 5 days, and I had nutritional ketosis, but not one sign of diabetic ketoacidosis, nor did the other person with type 1 either have any ketoacidosis issues.
Now, were your ketone levels higher than the participants without diabetes?
They were the same.
No, they're about the same. Yeah. Isn't that remarkable?
Yeah. So diabetes had nothing to do with that, really.
Yeah. That's great. Yeah. That's great. And I mean, such an amazing feat. 8 started, 8 completed. Fairly similar experience for most of you, it sounds like. You collected a lot of data. Was there other than the ones we talked about, was there something that really surprised you about the data?
We've got to analyze it all at the moment. It seems that the metabolic breath testing, which we did, was called the RQ level, I think, isn't it, to test whether we're fat burning, sugar burning. It seemed to be mostly fat burning, but 1 or 2 people throw up some surprises with respect to that. And there doesn't seem to be any trend for the group of 8 of us. There doesn't seem to be any consistency for 8 of us, which suggests that we're all individuals and we're all going to have to work things out individually. Ketone levels were not a surprise. I think the mood was the biggest thing that surprised me, the mood and energy that I had at days 4 and 5. I'd already done a 4-day fast and 13 miles a day, which is about 20 Ks a day. And that was all right, but I was a bit tired towards the end of that. But day 4 and 5 was a really high sort of point for all of us on the project. No
Yeah.
one was glad to
Wow.
finish. And interesting, when we refed, we didn't really overeat. Most of us just ate, what you call a normal portion, which is
Yeah.
interesting.
And that's so important for breaking a fast anyway, regardless of your physical activity.
Yes,
If you break it with too big of a meal or eating too fast, you could really get into some digestive
absolutely.
issues. So yeah,
Absolutely.
that's
Yeah.
important. So now looking in the rear view mirror, now that you've done it, you had some negative press, but mostly overwhelmingly positive press. In the rear view mirror, what do you think you've accomplished? What do you think might change because of this?
I think we've shown that type 1 diabetics can safely miss breakfast and not go into diabetic ketoacidosis. So I think from my point of view, from type 1 diabetes, we've answered every single concern of diabetologists around ketogenic type of diet. I mean, we've sort of answered that concern at an extreme state. I mean, it's very unlikely that anyone will want to emulate that, and I don't recommend it. It was an exploratory experiment, really, to see what happened. So I'm hoping I can use that to promote ketogenic diets as being safe, because we've shown that you don't need to eat sugar for energy. We certainly didn't eat any for 5 days, and we weren't lacking in energy. If you're taking physiological doses of insulin, you don't need to eat carbohydrates to cover it. And I think they're very, very important. And you don't go into diabetic ketoacidosis if you're type 1 on a ketogenic diet. So we've answered a lot of concerns. So hopefully, diabetologists will start to be able to feel more confident that they're not going to run into difficulties with their patients by exploring a keto diet with their patients. And it's quite a relief, as as doctors, as you know, it's hard changing paradigms when
Yes.
you've been okay with the paradigm that you're used to. So if you genuinely think that someone's going into diabetic ketoacidosis as a result of the keto diet, well, I would certainly, if I believe that, I'd be very concerned at recommending the diet. So I'm hoping we've removed some of those concerns, and we'll be able to move on a little bit with promoting ketogenic diets as an option for people with type 1 diabetes.
Yeah. Now, even despite this overwhelmingly positive experience, do you think there's still going to be some pushback from doctors, and they're still going to be hesitant to adopt it?
Absolutely. I
Yeah.
think there's unfortunately there's more to medical progress than science. The science, I
Well
think, is
said.
undoubted, but there's a lot of politics involved. There's lots of habits. There's lots of vested interests. And that will always exist. So all we can do is give the evidence and try to give people options, and hopefully, as more and more people discover this is an option, they will demand it, really. And at some point, people are going to get very, very cross indeed. And I know people get cross when they suddenly discover a way of managing their diabetes, and they've been struggling for 10, 15 years, and they've suddenly revolutionized their life. And they get a bit angry, really, that, well, why didn't they offer me this before? Because Richard Bernstein knew this in 1988. I didn't.
Yes.
I did discover it till 2015, much to my shame. And I try to just push it on now, to try to use my status as a doctor, if you like, to sort of move it on into to my colleagues and say, this is probably a safe option. Don't worry about it. Let's just provide this as an equal option to low carb, but talk about it as an option. Don't say, oh well, it's a fad, and you're going to get DKA, and oh, you've got to have no fat. If people want keto, they say, well, this is what you do to go keto. This is the diet you need. These are the things you need to look out for, and this is how you manage your insulin. If you want to go high carb, this is the diet you need. These are the things to look out for. This is how you manage your insulin. And I
Yeah.
don't think it's fair to apply current dietary guidelines to a keto diet, and talk about keto in a negative way. We've got to provide it as a good option. It's not like if I said, I want to learn French, I want to speak French, and they said, oh, you don't need to do that because all the people in France speak English. No, I want to learn French. So talk to me in French, and we'll do the whole thing, if you see what I mean. And I think
Yeah.
that would make it, and I think if we could provide equal options skillfully delivered, and then we all start to change the paradigm. But until we can teach the healthcare professionals that these options are safe and get good results. You'll get more than 10% of your patients to target. You'll get nearly all of them to target, and how wonderful that will be for the patient and your own sense of satisfaction. I think we can then start to change things a lot, but we've got got a long time to go. This is just one step on the way to hopefully changing attitudes, and I hope this contributes to it. We'll get some medical papers out. We've got a film on the way. We're just trying to reach more and more people so they may become more interested in it.
Yeah, great. Well, you certainly deserve a lot of recognition for what you've done, and not just as a publicity stunt, as some people initially said. I mean, as you've so well pointed out in this interview, there was a purpose behind this, a medical purpose, a purpose for helping people improve their lives and helping doctors improve the care of their patients. And I think you pointed out the points very well on what we should all take away from this. So thank you for doing that. Thank you for putting your neck on the line. It was you could say it was a risky process that you did, but you did it very safely. You pulled it off, and I think we should all learn a lot. So you mentioned a movie, you mentioned medical papers. So what else is coming next, and where can people find you to learn more?
Well, it's www.05100, so all letters and 100 numbers, 05100.com is our website where we'll publish everything. And then hopefully people will start to look at my own type 1 website, which is type1keto.com. It's the number 1 in the middle, and type1keto.com, which is where they'll find information on how to transition to a keto lifestyle in conjunction with their healthcare professionals. It's not particularly standalone. It's for them to work in partnership. And there's a lot of healthcare professional teaching on that site as well, which they're fully able to access without having to be a healthcare professional. So
Great.
Thank you. And thank you for the opportunity to talk about my favorite project of the year, 05100.com.
I think it might be my favorite project too. That was remarkable. So well done. And thank you. Thank you for joining me.
Thank you very much. That's great.